So someone want to know about carotid cavernous fistula. So it is, as it says, it's a fistula, which is an abnormal connection between like and unlike. In this case, in the carotid artery to the cavernous sinus. So you've got a vein and an artery. The cavernous sinus is now receiving arterialized blood. And so if you have the eye, the blood goes anterograde in the superior ophthalmic vein and the inferior ophthalmic vein through the orbital apex and supraorbital fissure to reach the cavernous sinus. And so if you have a arterial blood that is directing the blood anteriorly, that is going to be retrograde, and that retrograde will make the superior and inferior ophthalmic vein get bigger, and then you'll get all the eye findings of the red eye shunt, because the flow is going the wrong direction. So arterialization will be seen in the conjunctiva. We'll see that as squiggly, dilated, tortuous vessels on the conjunctiva and episclera. You'll get ophthalmoplegia because the muscles are all full of blood, and you might get vision loss either from a vein occlusion or from ocular ischemia or from optic neuropathy. If, however, the flow is posterior in the carotid down the petrosal sinus, from the cavernous sinus, which is the major draining vein of the cavernous sinus, the inferior petrosal sinus, you'll only get cranial nerve 6 palsy, and you might get pain from the cranial nerve 5. So it's going to cause a white-eyed shunt. The eye's going to be white because all the red eye symptoms, which would have occurred from retrograde flow into the vein, are not occurring because it's only going down the petrosal. And it's usually only the 6th because the 6th is inside the substance of the cavernous sinus. And so the combination of a painful, progressive, and persistent 6th, you still got to think about a wide-eye shunt. And sometimes the wide-eye shunt becomes a red-eye shunt because the thing gets bigger and bigger, and then the flow finally goes anteriorly. We normally start with CT, CTA, MRI, MRA, and what we're looking for in the head and orbit is the enlargement of the superior ophthalmic vein and the red-eye shunt. However, really, if you think it's a fistula, you have to do a standard catheter angiogram. There's a classification system for the carotid cavernous fistulas. The Barrow classification tells us where the blood flow is coming from. If it's a direct fistula from the internal carotid artery, that's a type A fistula. If it's a B, C, or D, these are low flow fistulas from branches, external and internal carotid artery, or both if it's a Barrow D. The other classification, and there are other ones, but we use Conyard, which is just telling us about the cortical venous drainage and the direction of flow. So if it's a Conyard 1, you generally don't have to treat that because that is anterograde flow. It's just going down the normal pathway. And if it's 2, we got 2A and 2B. And the line for treatment is this 2B because the thing that's dangerous in carotid cavernous fistulas is cortical venous reflux or cortical venous drainage. And once you have 2B, that's when the cortical venous drainage occurs. If you've got venous dilation and cortical venous drainage, that means the vein is bigger and draining the wrong direction. That's a 3. And then if it's big and you got venous hypertension and retrograde, that's a 4. And if it's draining into your spine, that's a 5. But really you only need to know that 2B or above is a dangerous one because of cortical venous drainage. So we need both the Conyard and the Barrow classifications for carotid cavernous fistula so we can answer the question about whether we should treat this or not. But in general, painful, progressive optic neuropathy or ophthalmoplegia due to a fistula needs to be treated. As soon as you're 2B, cortical venous drainage, that's dangerous, needs to be treated. And you need to know the difference between a red eye and a wide-eyed shunt.